So I'm Scott Williams with United Healthcare. So I lead all of our payer contracting in the Pacific Northwest. I've been with United for almost 4 years. Prior to being on the carrier side, I was with Legacy Health and did a lot of population health care transformation type of work with Legacy Health. One fun fact about me is I'm Canadian, or I was Canadian. I should caveat that I was Canadian. I gave it up for the U.S. government.
Hey, good afternoon. Cliff Hendargo. I lead the payer contracting functions for Peace Health in the states of Alaska, Washington, Oregon. I've been here with Peace Health for about 17 years now. Prior to that, I originally was from Southern California, so it's been really an interesting dynamic on, the managed care space in that state and up in the Pacific Northwest. Very exciting, though. A fun fact about me. Let me just say, I enjoy miniature wargaming. Look up Games Workshop, and you'll know what I mean.
Hello, this is on. Yeah. Hello, everyone. I'm George Harper, the Senior Director of Provider Partnerships and Contracting at First Choice Health. I head up the provider contracting team for our 10 states. I have been with First Choice just over 22 years, almost 23 years. And a fun fact about me, my cat has an Instagram account that has way more followers than I do. So there you go. Either I'm boring or the cat's exciting.
Hi, I'm Suzanne Daly. Nice to be here with all of you. I lead payer contracting for MultiCare Health System. And I guess a fun fact about me is I used to have Scott's job, and occasionally he'll find a memo with my name on it and send me a photograph saying, you need to come get your files. A long time ago. I'm much older.
Long time ago. Good afternoon. Todd Lovshin with PacificSource Health Plans. I serve as our Washington market president. I've been with PacificSource a little over 10 years. Started with the plan when we moved into Montana, and have been here and living in and working in the Tacoma area for the last 4 years. COVID has made that seem like 14, and then at some days like 2 days. Fun fact, I am also a ballroom dancer there. I haven't actually danced in many years, but I danced professionally in college. So,
Do we just go down the line? Okay.
sure.
Okay. I'll try to be quick,
But
but
make you start each time.
The fantasy snake draft. Go back.
healthcare is very much a relationship-based, ecosystem. Anything that we do has a impact and reaction. As you think about like the day-to-day contracting activities that we do, it's all relationship-based, right? There's business involved in that, but you base your trust on your relationship with the contractor that you're negotiating with, or if you pull up the strategies that you're pursuing, whether that be for an entire line of business or a certain care delivery aspect. It's all very much relationship based, and anything that we do is extremely important that we understand each other's sides, so that we're clear in understanding the transparency of what's happening. So that's how we pursue it in the Pacific Northwest with United. It's all very much relationship based, trying to be as transparent and open as possible.
Well, I'll sum up into 2 items, really. I mean, I think the core of it, the core of it is, we're in healthcare because we want to ensure that anybody who needs healing can receive it, right? And, some of the touch points in the patient, we have this model of patient-centeredness where you have the patient in the center and you have all these different touch points like the physician, family, et cetera, but the payer is one of them. Right, the payers is one of those touch points that are also important, and in my opinion, right, the revenue cycle doesn't start at registration; it starts before that. It starts at what coverage does the patient want to select, right? Be it their MA, commercial, and even within that, are they traditional with SUP, et cetera, right? It impacts how they access care and how they see care, right? So the first piece of why it's important is that we need to work together to ensure that we're meeting that same goal of access, improving patient experience, improving quality outcomes. The second piece, though, is the expediency to get there, right? When we collaborate and work together, we get those results quicker, it's more efficiently, So, those two things, in my opinion, sums it up.
Just to start out with, I don't know how many people are familiar with First Choice, but one of the interesting things about our company is we are hospital and physician owned, which, that goes in with the partnership and collaboration with providers, not just because they're owners of us, but also because, we both want to be successful as a health system and as a provider payer. And so I think that the way that we work on that is we collaborate together, we partner together, and we build good relationships, because without each other, I don't think we're going to be very successful individually on our own.
Collaboration is pretty key. MultiCare, in its vision statement, talks about partnering, and we view payers as part of our partnering vision. I think when our focus is care delivery as providers and a payer's focus is benefit administration and financing that care delivery, we have to collaborate in order to just have efficient revenue cycle functions, as somebody mentioned. But the deeper collaboration that we can get to can transform the payment model so that we could create a different care delivery model. So an example might be our Mary Bridge Complex Kids program. Think of it like an intensive outpatient clinic for medically complex kids. 75% of the services provided aren't billable under your traditional code-based revenue cycle services. So if we don't partner with payers to think about a different funding model to support that differentiated care delivery, we can't offer that service, right? Unless we have a very great fundraising model through our foundation, but it's such a much better way to deliver care to those kids, not through the ED and not through hospitalizations, which you can code and bill for, but through wraparound ambulatory services. So that's one example of why we think it's important. We also want access to patients in our markets, and payers call them members, or enrollees or beneficiaries, and we call them patients or our community. So in order to really be effective in serving our community, we need to have really effective, strong relationships with our payer community.
Thanks. PacificSource is a not-for-profit regional health plan, Oregon, Idaho, Washington, Montana. We take that not-for-profit and the regional health plan really to heart. And I always say, it's almost pat when you say, oh, our provider partners and that term partnership. For me, the collaboration and the working together and focusing on mutual growth and mutual objectives of how are we truly serving a population, and how can we build the models and not just finance it, which is a health insurer's job, right, is to finance healthcare, but is to make sure that we're impacting the communities that we're in. Are we building access points? Are we creating an environment where we are focused on wellness, not sickness? And what are the things that we're doing in order to support that? And frankly, we still have to take care of the sick patients too, so how are we making sure that the revenue model and the streams there are supportive of that community and community growth? And so for us, it is part of our DNA. We were founded by providers. Legacy Health is one of our partners in the overarching corporation. It gets really complicated with not-for-profits, right? They're a member of our corporation. And then for us here, it's just throughout Washington, is how do we partner with folks like MultiCare and others to really bring our services into that market and grow our membership. Yes, that's an objective. It's in my yearly objectives as well. But also, how can we really impact the health in the communities that we're in? We're a new entrant into the market here in Washington, and so we're really collaborating and really focused on how can we be of service to MultiCare's mission? How can we be of service to other providers in the community? And again, we need to create our membership and grow that membership so it's relevant in the communities. But also, let's see, wow, you're gonna have to help me on that one. Also how we want to show up, right? We're focused not just on what is the negotiation and what are the product lines, but what are the product lines that the provider also needs us in, right? If we just want to be a Medicaid provider, that's probably not going to be the best thing for a depth and breadth within the community and for that provider. So where would they like us to focus? Also, where do they want us to steer coverage? Right? So it's not necessarily, is it a better avenue to utilize some of the FQHCs and to utilize some of the lower costs of care centers besides urgent care, emergent care, and things of that nature. And so how are we really working together to make sure that we're wrapping our arms around our joint population, our joint membership, and getting them to the places that they need and the healthcare that they need. So that's why we collaborate. I mean, we have a lot of regulatory environments that are forcing us to really think about how we bend that cost curve, how we do some important work in that regard and within that policy. And so we can't do that unless we're collaborating and having those truthful, honest conversations about how we get there.
Been working with PacificSource for 4 years. Pandemic, you're right. Can't do math anymore or time anymore. For 4 years, collaborating for their entry into the Washington market. A couple of the ways that we partner, not just with PacificSource, but with other payers, would be on product. What products do we want to offer? We have multiple accountable care organizations that we work with. MultiCare Connected Care is one. We have a partnership with UW through Embright, which is a narrow network collaboration that administers the Boeing contract and the Healthcare Authority. And we have Physicians of Southwest Washington and now Signal Health in Yakima. So we partner with payers around how can we structure population health initiatives around those clinically integrated networks. We partner a lot on data. We've been lately partnering around interoperability and prior authorization and trying to take some of the inefficiencies around how we manage that interface between the care we provided and getting that care paid for so that it's lower cost for both parties.
For me, collaboration kind of takes on many different shapes and forms. For example, we are a preferred provider organization, so partnering with providers means making it easier for you to access all the information you need to from our 70 various clients that access our network of providers. We are also a third-party administrator, so collaboration takes on the form of working with our employer groups, which are oftentimes health systems, on developing the right benefits and the right network structure so that the employers can drive cost and drive down cost and increase quality for their employer plans. We also partner with quite a few accountable care organizations in Washington and outside of Washington: MultiCare, Connected Care, Embright, Eastside Health Network, Midwest Network Alliance in Nebraska and Iowa, an entity out of South Dakota as well, where we work with those entities to promote their name over the name of the administrator. If you look at net promoter scores, health systems have a much higher, more recognized net promoter score than, say, your typical insurance company or a payer. So we partner and collaborate with the plans to lead with the provider's name and do the administration on the back end. Thanks.
Well, how we collaborate, and I'll just pick on United and Scott here just because he's right next to me, but it's yeah. But it's a key focus is really being transparent and having direct communication, constant communication, right? There are several levels of how we do this because healthcare is complex, right? At the base, there are just basic items like, hey, can we just get our claims paid? Can we get the funding in so we can provide care? Can we get access to getting patients out through the care continuum? Like, how can we be more efficient in removing some of these barriers to get us, from acute to post-acute, et cetera, right? There are those conversations. There are conversations at a higher level in how do we move towards more value-based care? How do we become more transparent in the data sharing, as Susan mentioned? Because that is an important piece, because we have a component, they have a component in the data set. How do we marry that and understand the populations we're working with? We also look at a strategic level, like in each market, how do we work together so that we can, coordinate the care to our CIN, to our DCE, right? So it's a myriad of those levels, but I think the key piece of the communication transparency is, I have a strong working rapport with Scott, right? But for a long-term partnership, that relationship can't just be at this level, right? It's got to extend down towards our clinical operational leadership, right? So what we're doing is, I'm having my CMO talk with his CMO, on a regular basis on, hey, what are some heartburn touch points that we have, and how can we understand each other, understand where we're coming from? Because oftentimes it's that misunderstanding of, how it impacts the other party that results in some of this, I guess, quote unquote, abrasion, right, between the two organizations. So the communication beyond just us, down to all the different levels, to our teams, our care management teams, and so forth, our data analytics team talking with each other at all these levels, I think is vital in how we collaborate with each other. Right, because the relationship, though, we have a long-term vision, and we hope we have a shared long-term vision. But to see it to fruition, it requires many levels of organizations.
I think for me, I echo a lot of what the panel has said. We think of it in what I would consider three verticals. With commercial, Medicare, Medicaid, each has a little bit of a different collaboration for them, but and then there's underlying currents of each one of those that cross-sect them. Value-based contracting is one of those, trying to move the needle. What we're doing towards all things moving the risk spectrum. And that is definitely one of United's desires, is to figure out how do we move down, the path towards our ultimate goal of global capitation. And so that is one piece of it, because there's a lot of collaboration that has to go on as we think about, well, how are we going to do the back end management of that? And that's not something that you can do in a silo. The other big piece that was also spoken about was the interoperability. So interoperability for us is, what we feel is going to solve a number of complex issues, front-end revenue cycle billing issues, back-end revenue cycle issues, as well as helping the providers at their fingertips around the individual member prior authorization request, and having understanding of what their COB or their COC is telling us or telling them, and what they're able to produce or serve that member with. The other couple of things, it's going to help build the tunnels that are going to be needed to support value-based care and risk. So if you have the clinical information and the claims information needed and the members' information needed at the fingertips, that's also going to help advance it. So we think about, specifically in Medicare, where, everything around HCC, RAF, gap closures is a big portion of your payment, or at least the payer's payment from the government, that would get passed on through a value-based contract. Those HCC gap closures are critically important, on top of, we think about stars and the caps that go into it as well. And then the other piece that I think a lot about is how do we invest in the community Specifically, we know that our Medicaid populations have a lot of needs, so we have to listen to what our providers are telling us, where that need is and where we can help invest, whether that be through a contractual arrangement, whether that be through a grant. It's something that we use eyes in the ears of our provider partners to help us understand where we can lean in differentially. I'm sure I'm leaving out some things, but
So how it's impacting our relationship with providers? Well, as I mentioned multiple times, we're provider-owned and provider-centric, so we're trying to be as supportive as we can with our negotiations with the providers. But we are also solely in the self-funded business, so any increase that happens, we don't collect premiums, first of all. So any increase that happens in the contract front, that is passed on directly to the employers that use our network or access or we administer benefits for, as well as directly to the patients and participants as their out-of-pocket costs increase. So we're trying to balance that aspect when we're in the middle of contract negotiations. But at the end of the day, really, the financial situation of hospitals in Washington State is pretty scary at this point. And we're doing everything we can to make sure that we don't end up in a worse off situation. So, we're being as supportive as we can, trying to be more creative with how we negotiate the contracts, and hoping that there's a parity in play with across the field for all payers.
I'll go next, I guess, if I may. Yeah, so, with the current socioeconomic impacts from in the last couple of years, it's had a huge influence on how we work with payers, especially like at, Peace Health, who's historically been very hospital-centric, right? And that makes it difficult when you have the COVID pandemic as an example, right? So it changes the mindset and accelerates the desire to, let's say, diversify our portfolio of our payer agreements, from like strictly fee-for-service to more getting stronger into the value-based environment, becoming successful in that field. Because instead of trying to chase revenue, which is the core of a fee-for-service transactional agreement, now we want to look at how do we manage to a budget, right? Which is the more premise of a value-based type agreement. So I think it drives more to that factor. And ultimately, I think when we think of what does the patient want, right? We're in a service industry where patients don't really want to use our service, but they're glad that they have it when they need it, right? Like, no one wants to be admitted to a hospital. No one wants to go to the ER. It's something that's like I'm glad I have it, but I don't ever want to have to use it type of deal. So with that, we look at, let's go to an ambulatory focus. How do we, keep patients on the ambulatory side? How do we keep them well, right? So they don't have to come in and utilize, our hospital services, if they don't need to, right? But then how do we create a payment model that supports that way of thinking? That's I think the desire with the social economic climate that's accelerated that thought process to get us there quicker. And to my first point, that's why I think the collaboration with payers is important, because it helps get us there more efficiently, not just like in 5-10 years, but more of like the 1, 2, 3 years, like in the immediate future. So given that piece, I think, it's also lots of pressure from the governments to like reduce the cost of care, right? And, how do you reduce the cost of care, right? I mean, the easy way is to slash rates, but that doesn't work for many reasons. And I think I don't have to preach to anyone here to explain that. So, how do we create more innovative models of care? How do we work together with our payers to develop something that works well, that we can deliver care to the patient in the way that they want to receive care, the way that, that works, that is also financially supported for the provider and makes sense to the payer as well?
Biggest shift for us is we don't really do 3-year contracts anymore. We do shorter term contracts because there's so much uncertainty around the environment and how long this level of inflation is going to be sustained, right? We know we're not going to cover inflation through Medicare. We know as a hospital, the state hasn't increased Medicaid rates in 20 years. So we know we can't ask commercial payers to cost shift and cover everybody's inflation, the 30% or less for us of the of the population that we can negotiate. So we are seeking higher rate increases than we have. I do remember when I first came to Washington, it was pretty typical to have a 5 or 6% rate increase. It's very, even now with high inflation, it would be very unusual to ask for something that high. But we are really not doing long-term agreements anymore, which is unusual. We are in our value-based contracts where we're managing population health, but in fee-for-service, we're probably like you all are trying to figure out how long is this labor issue going to sustain, how long is the high length of stay going to sustain, and how can we really kind of, we tend to think of things in now, near, far being 5 years, now being now to the next 6 months. We're really focused on now and our payer conversations.
Yeah, it's certainly has impacted, and as we go out and have conversations with providers, they're wanting a certain rate. I want to go back to what it puts pressure on us to do is to really think about the value-based arrangement and risk sharing and other types of arrangements that we can really jointly focus on the population and how we're financing to the budget that is needed, but also meeting some expectations. I like to point out as a payer, right now I'm in the Medicare sector getting ready to, in final bid preparations for Medicare Advantage plans. Those go in June, but we're in the middle of that process right now. In the individual and small group market, we're about to file our 2024 plan designs and rates, and with the Insurance Commissioner's Office across all states. And so sitting down and having a conversation with a provider or provider partnership to say, we're really a year to 2 years out before we can make significant changes in premium or premium dollars, depending upon the product cycle. And where can we make the easiest, quickest changes? Large groups. And those, to Suzanne's point, we can't continue to balance that budget off of the large group or the self-funded arrangements. We have to think about it more long-term. And so we really look at it as how do we move more and more into the value-based arrangements, knowing that not all of our provider partners are there. But are there steps that we can take to move to that, and how can we do that together? And I think that's just really an important part, is the quicker we can get solely away from fee-for-service in some of these environments, the better we have an ability to more globally manage the budget together, which is why I really enjoy collaborating, and that we've got to be really transparent and honest about what is needs in order to be able to give the services and make them work in the community.
Think about a lot of stuff while I was listening to that, especially around the product cycle. And to your point, Todd, I mean, you're planning sometimes upwards of a year ahead of time. And to Suzanne's point, these 1 and 2 year deals makes it very difficult to figure out what the budget's going to be for your product and how you're going to file it. Even in the Medicare space, it's, I know we're having challenges because you want to put any extra cash that you have into the benefit structure, and that's where you really compete in the Medicare space, is having richer benefits, and it's a challenge in that space. But I will say, since over the last 2 years, there has been an acute, I would say, focus from a hospital standpoint and understanding their finances. I think none like I've seen before. And it's opened up a lot of interesting conversations, and I've learned a lot about revenue cycle and all the back end stuff more than I ever wanted to. But, at the same time, you hear and read the articles day in, day out about the financial struggles that our hospitals and our providers are having. And to be a good partner in that, you have to go down these rabbit holes. Rabbit holes is a bit derogatory for the pain that's going on, but you have to go down these paths with the providers to understand, okay, what is the root cause of these issues, and are there solutions that we can pull forward for you? And so we've been on a lot of those discussions over the last, I would say, year mostly, and it's been a big learning curve, I would say, for our organization as well, on how we're going to approach it moving forward. But there's one other thing I wanted to say, but I forgot.
Right. Yeah. So I think, to be successful in value-based care, it requires quite a bit of infrastructure, both on the not just in the capabilities of the people running the organization, but also the technology, the data share. That's important. I mean, leveraging technology is vital. I think a couple panelists have mentioned that, and Peace Health would concur. But that's also some of the barriers as well as in some of these organizations, in terms of going that direction. I mean, Peace Health, I think, is fortunate where we are a large enough system where, we can invest in that to be successful, right? We have the investments to, purchase or build or train our own infrastructure in terms of the care management, the technology, the analytics, whatnot. I mean, an example is moving to a DCE model for a Medicare population, our single largest payer. Now it's going ACO REACH, I'm sorry, but that's I think a big step for an organization like Peace Health, who's been largely fee-for-service based. And I think that the difficulty with the haves and have-not is one is the mentality to move from fee-for-service to value-based, right? It requires a big change in how you think about the care, about your production model, because our physicians have a set comp model prior, when we were largely for fee-for-service and versus now, right? There's different incentives, different ways to think about that. So that's one piece. Another piece is the technology, which becomes a barrier for a lot of the small practices who can't invest in that. I mean, building our CIN, I think part of the challenges with some of these smaller groups is getting them on one EMR, right? So we can all connect and all coordinate together. That's been a challenge for some of these smaller groups, So I think what I mean by diversifying portfolio, I think we take steps to get there. I mean, it doesn't make sense for us to all just jump into it and ditch all our current fee-for-service agreements. But where does it make sense, right? So, like with Peace Health, we started off with Medicare, our single largest payer. So we did that on reason so we can also create a standard way of practicing care, right? Because you start with the largest payer, it's easier to standardize how we deliver and interact and whatnot. And how do we leverage that beyond Medicare, the other populations, like our MA population is our next target, and we're looking at Medicaid and commercial as well. But growing that infrastructure, and also how do we help bring in other smaller provider groups who want to partake, who want to understand how to be successful in value-based care and as part of our CIN. I think that's also some of the conversations we're having today with our other local groups. And there are some barriers because of that, because they don't have the luxury of of the dollars that we can spend towards transitioning. It is an investment, I'll just say that. I mean, just to get there, to be successful, it is an investment in time and resources.
I would say that the current financial situation has accelerated the move to population-based care, value-based care, in that if we have a patient that we know we are not going to be able to provide care for that patient and get compensated for it, we're gonna, I think Medicaid covers 67% of the cost right now. So if we're going to be investing in care for that patient in an expensive setting, we're highly incentivized to not have them be admitted. Right? Better to never have them be admitted to the hospital, send dispatch to their home, do an urgent care visit in the home, do an urgent care visit under the bridge, do an urgent care visit wherever to make sure they're not readmitted, which is care you're going to incur cost and not get paid for. So it's really accelerated, I would say, our thinking about how we can shift toward value-based care, providing care in lower cost settings, transitioning people out of hospital-based care because we don't have capacity anymore in our beds. Our beds are full. So it's created a really interesting opportunity to align around managing to a budget, managing to a medical cost target, and moving away from episodic reimbursement. And all the things that Cliff said about aligning providers that can't afford the investments.
Yeah. For us, it certainly has enriched the conversation with smaller providers in ways, to Cliff's point, there are investments that are needed, and but I always go to, I'm a former, I worked for politicians, I'm former insurance commissioner, deputy director in Montana. I always go to the regulatory environment in ways of saying that, we have the Healthcare Cost Transparency Board here, we have the BRE Collaborative, the HTCC work, we have the exchange setting policy and what they want to pay for and other things. And it really just, I know we're talking economics, but this is just continuing to put more and more pressure as the regulatory bodies and the health policy bodies continue to make these rules and objectives to say, this is what we'd like to see. 3.2% cost growth in our medical trend year over year is going to be really hard to get to, right? Given inflation and given all of the other things that we just talked about. And so couple that with the economic realities of traveling nurses and all of the other things going on, how do we as partners in this either get there or help make the policy case that we can't get there, and we're going to need to do that together, right? We're going to have to understand it. We're also going to have to think about it in terms of, are we doing everything absolutely necessary or everything that we can in our power to get there in some sort of way? And I think that's what's accelerated sort of that value-based discussion. It's also made us think about, and we've always been there from a company perspective, not everybody's going to be at land 4 in 1 week, right? We're going to look at how do we get there, what is an initial sort of value-based arrangement, what does that look like, what is that provider capable of, and then how do we help build that over time as we grow our mutual populations, but also as we grow that muscle memory and that strength to be able to do that. So I go immediately to, if we're not collaborating as an industry, not just as us in MultiCare or us or Peace Health, but how are we collaborating as an industry to really show the policymakers that we have the same interests that they do, and let's move that forward in a way. So I continually go there. Economics are just going to force this even farther.
Yeah. I would agree with everything that Todd said again, because we have had our ears to the ground with what's happening with the benchmark work, both in Oregon and Washington, and how that's going to unfold. But I think, from a United Health Group standpoint, it's our desire to move the risk spectrum all the way to global cap. And so we have a care delivery arm set up for that. And we're moving everything into global capitation. But you have to have the infrastructure and you have to have the wherewithal to be able to do that with your DOMERS and DOFERS, Division of Financial Management and Utilization Management. And then you have to have, as we think about in the Medicare space, CAPS is heavily weighted towards patient experience. So you have to have the infrastructure, the staffing, the FTE staffing, to enhance your CAP scores, or else your payment is going to be dramatically impacted. Same with having the wherewithal and the knowledge at the fingertips of our providers of closing HCC care gaps. So that is a lot of infrastructure, and I would say my worry right now is not necessarily for a large health system like a Peace Health or a MultiCare who have a little bit more resources, but pulling along our smaller hospitals, our smaller health systems and provider groups into that space, and how do we get them there? Because in my experience, the ACO realm is a great way to provide the upfront no risk incentive to invest in there, but it's not getting you into the full budgetary type of global management, which is a whole nother realm of risk and value-based care. And if you're truly going to manage at a global risk standpoint, you have to have that whole infrastructure to be able to do it and move the dial, I think, in budgetary management.
One area that I think we could all collaborate on more is working with employers and brokers to have them understand the purpose of value-based care. I think all health systems, all payers are interested in moving this further down the line. And a broker-employer group thinks to themselves, what's value-based care? That's lower cost, higher patient satisfaction, and increased quality. Which to them, I think sometimes can mean it's a race to the bottom for the lowest reimbursement possible. And given kind of the tough economic times we're in right now with the inflation issues, brokers and employers are struggling to understand the value of value-based care, the value of getting involved in this, because they're looking at their cost of care from 2 years ago, 1 year ago, to what their trends are now. And they're saying this isn't producing a lower cost of care right now. They're not looking at future outcomes or future initiatives, but they're looking at the immediate impact of it. So I think as payers and providers, that is one area that we could collaborate on, in addition to the policy aspect, is to get more employers and work with them to understand and truly appreciate where we're headed with this.
We're really rethinking our primary care strategies. So one of our leaders said in episodic fee-for-service primary care has always lost money, for those of you that are not in the primary care business, but it's your front door to your specialty referrals and your hospital admissions. Now primary care is how you access covered lives, and it's how you capture value-based revenue in a global budget, right? It's through attribution or assignment to primary care. So we are looking at standardizing primary care. We have different versions of primary care between our big multi-specialty clinic in Spokane and our MMA 28 clinics in Western Washington. We have primary care that we're going to start offering through urgent care, our Indigo locations. That'll be basically on-call walk-in, but primary care. We are looking at advanced primary care, which is, chronic patients assigned, and it's a much more intensive model. So I think it's really without access, we're going to have people show up in the ED in the hospital. To my earlier point, that is the most expensive place to treat people. And at this point in time, the expense is greater than the reimbursement we're going to get for treating those patients. So we need to really invest in order to make care delivery work and in order to be successful in value-based care. So primary care is huge. Terrible.
Again, I think of it in three verticals. Within each line of business, Medicare, we're partnering with our provider partners to say, where do you have staffing struggles today? Pharmacy is one of those big ones that even a lot of small practices don't have the volume to fund a pharmacist. And so we're embedding pharmacists into some of our health systems and some of our smaller practices. We have QFO support or quality support in Medicare, as well as house call clinical staff that go out to our members' homes. So understanding and partnering with our health plans, or our health systems, where the greatest need is and how we can supplement that from a health plan standpoint. From a Medicaid standpoint, we're partnering with a number of unique, groups or organizations out there, again, to help supplement some of the, I would call it, at the hip type of clinic work in engaging members, because we know that our providers don't have the time to be doing that. Also, our clinics don't want to be, staffing and managing MAs and pharmacists and other clinical staff. So if we can supplement that and help the provider really focus on providing the care, and we're the ones that are engaging the member and bringing the member in to close those clinical care gaps, that's another critical way that we're looking to partner with them as well.
On a couple of things that both Susan and Scott mentioned. I mean, I think primary care and access there is a key starting point, right? And the challenge with the primary care that we're seeing is each patient segment has a different expectation of what primary care looks like, right? That's a big challenge. I mean, you have your, and I'll speak in generalities because I know it's not definitive, but your Medicare population, which wants that direct connection with their provider, that long-term connection with one provider that they can build throughout, right? Then you have your commercial who wants more of the on-demand care, right? They don't really care if it's the same provider, they just want to get in when it fits their schedule and get out, right? So then, and then you have the other Medicaids that sometimes has some social determinant barriers to get access to care. So it's a different strategy to address all three segments, right? But primary care is vital. I mean, like for example, on the commercial side, we've acquired Zoom Care as a way to provide on-demand care to patients who want that, right? And I think it's been a big success in that demand and meeting that need. On the Medicare side, we've also invested in hey, how can we, create that capacity by the offset to Zoom, right? So we have that segment there opens up capacity to our MA space to also create that connection that those members want or patients want. And the socially determined barriers, which actually does impact all three segments. That's how we look at how do we partner with community agencies, how do we partner with payers to address those issues of transportation, getting access there, getting access even like just common like food and addressing the food deserts. How do we address all those so that, in a sense, it creates that ecosystem where the people who really need to come in can come in, and the ones who can be care managed can also be addressed that way, and it lets us meet them as to where they want to be met. I think that's the key piece, right? Where does the patient want to be met? And we do other services, like we do the home visits that we've built. We're looking at expanding our ambulatory capacity, like our outpatient imaging, ASCs, et cetera. There's other lower cost options. So there's all that work as well.
Move more towards virtual care, whether it be video or even text-based care, could kind of help bridge the gap. It took a global pandemic for people to actually start using telehealth, and I think it's time to just kind of push that a little along, find different solutions for it. Other tech-based opportunities might help with the issues at hand.
I'm not sure I have much more to add that has been spoken to. I think it's important that we as payers also look at what is that reimbursement model, and are we engaging so that we can help build that access? Are we helping make those investments so that we can build that access? In 2025, the Insurance Commissioner's Office will not just look at whether your network meets adequacy, it's whether or not there's access points that are still accepting patients. So we have an inherent reason to continue to help and to help build that infrastructure, right? But also, are there, I think when MultiCare brought Dispatch Health on, making sure that our contract supported that and that our Medicare Advantage plan had that available and that we could build that into the contract as well. those are important things, and that gets to that early conversation so that we can make sure that those things are built into, and in some cases incentivized from a product design perspective to be utilized. Maybe to Cliff's point, that it might not be the same primary care doctor that you see or the, each and every time, but you're going to get to a clinic and they're going to take care of you, and that's part of the access, and that information is being shared back and forth. So I think in addition to that, hopefully we answered your question. Yeah. Yeah.
Hello?
Gotcha.
I would appreciate hearing the panel response. My question will be around prior authorizations. And so just, a couple, obviously, within the past year, there's been more publicity, potential legislative action, attention paid to the administrative cost of prior auths, probably compared to the previous 10 years. So with that, kind of the provocative supposition, if you have a reaction to what I've potentially heard, that through potential legislative regulatory focus, limitations, and with improvements in AI and other technologies where providers are now able to be more efficient, and a component of prior auth where there are administrative savings due to slip-ups diminish with the increased legislative pressure. The provocative question is, are we potentially now at a point where the value of the prior authorization perhaps diminishes, and that is a period of our healthcare life cycle that potentially will diminish and become a less effective tool?
I think the government is going to force many health plans to go down this path.
Yeah.
I think right now, it's obviously a little bifurcated by state. Texas is, I think, probably leading the charge within the nation, but I know it's either in the House right now. Is it a House bill that's getting pushed in Washington?
Yeah.
And so knowing that, each state, whether at a House or Senate level, is evaluating it, I could tell you at a United Health Group level, it's already being socialized and worked on. And what I would tell you is we are evaluating, I hesitate to say gold carding, but how do we evaluate who gets a prior authorization waiver over others? And as you look at it at a global level for United Health Group to eliminate a number of basic prior authorizations. Financially, it is a loss. However, there are upsides that we're evaluating as we think about the patient experience within that too, and the value of patient experience and NPS across our lines of business as well. So it's something that United Health Group or United Healthcare is evaluating and probably be more public about in the near future. But I think everybody's hands are going to be forced to do some level of prior authorization exemptions in the future around a handful of cases, right? We're not going to be doing any major complex care prior authorization waivers, but for basic things like colonoscopies, CT scans, MRIs, those types of things, I think we'll see a little ease and relaxation on.
Sure, I was just going to build on that a little bit and say, for PacificSource, we continue to take a look at prior authorizations. I agree with what Scott was saying about regulatory and that we may be forced, but as an insurance company, if we're approving 90% of prior authorizations, why are we doing it? And we really have to ask ourselves those questions, right? Like, why are we really doing it? And so we've done that. We continue to evaluate that and to take a look at that, and in some cases remove them, right? And then also, I think when you start sharing data and you start sharing in both the risk and the value-based arrangements, you start getting to this point with your partnership that you can say, well, we're both kind of on the hook for it, right? And so how do we manage that more, effectively together? From an insurance perspective, we need to make sure that the process is quick if we're going to put that in place, and we're going to make sure that there's a value to it. And that's been our focus, and we'll continue to do that. We do some gold carding, to use that term, and we've heard from our payers or our providers that saves significantly in administration. And how do we build that in, and how can we help in that regard? It also, at the end of the day, I think we make healthcare very complicated, right? And
That's a standing ovation.
yeah, but I think we do it in some ways because we've been forced to in Medicaid. There's rules, you must prior auth certain things. In Medicare, there's certain policies that have been driven over time, and then in commercial, we've sort of adapted that, and this is where I love the work when we sit around the table and we not only collaborate, but we're focused on what is the global budget, where is are we focused on this population, and what do we need to do there? I think that's the right answer, and hopefully the policies and so forth will work themselves out over time.
Yeah, I think when you think about decision support aids, we have one on the front end of our imaging platform in Epic that mirrors exactly what a payer prior auth for imaging would look like. So what's the value of a prior auth process when, to your point, 98, almost 99% of the time in some cases, you're just creating a delay for the patient getting access to care, right? So to the extent that we can be good actors and demonstrate that we are appropriately referring patients into care, which again, fee-for-service and global budgets align our incentives to that end, we should be able to get rid of some of this administrative waste, to your point, that again, gets in the way of patients getting good access to care.
Yeah, and that's where I was going with both your comments. It does delay access to care, and also, it doesn't incentivize us to move into value-based if this is kind of a barrier, right? So I appreciate the requirements that the payers have to implement some type of policy, right? But I think I also want to add that when we think of prior auth, we also think about the auth to the post-acute side, right? Because that's been a huge barrier block for a lot of health systems, right? Capacity in acute is very vital, right? So not only do you delay access to the patient needing post-acute care, you're also blocking a bed for someone who needs that care on the other end, right? So there are two components of here that gets impacted by having a prior auth process. I know we typically think of prior auth of like imaging and procedures, but I think the post-acute piece is also vital to address. So yeah.
Yes.
72 hours to authorize. And if a payer takes 72 hours to authorize post-acute care, they're typically straddling a weekend, so they'll typically want another OT and another PT assessment, and we spend all our time just doing OT and PT assessments, and it's crazy.
And I think let's talk about collaboration, and that's where if we were to come together as a health plan and a health system and have more understandings of okay, what are the root causes, right? Yeah. From both ends. Because the reality is cost savings isn't in the prior authorization. The true cost savings is the length of stay in the post-acute care space. And so if we can better understand what some of the challenges are in the prior authorization process, we can work through challenges, right? In many cases, I will say. But it is easier to build things than break them down.
Yes.
Oh,
Go ahead.
yeah, separate question. You know, we're talking about currently, but if we talk about the future, I have two questions, one for payers, one for the providers, as it relates to hospital at home. And hospital at home would look at 30% reduction in cost, high patient satisfaction and quality. So from the payer's question, are you currently paying for that now? And what is your plan for paying that for the future? Because when we talk about the partnership, that reduces cost. For the provider's question, are you doing a hospital at home now, or do you plan to do it because it actually lowers the cost and helps alleviate the access problem? So two different questions.
So Scott will speak for Scott. United has, the pandemic allowed CMS, we filed I can't remember what it was called, but there was a particular waiver at Good Sam, where Marnie leads, where we could admit Medicare patients only to a hospital at home program, and we have one. We hit, like all hospitals, last January of 2022, just massive demand for hospital care that we couldn't meet, and we were working to admit 2 patients a day, commercial Medicare, Medicaid, into our hospital at home program, and just called payers to say, we're going to do this, otherwise they're going to sit in the ED for hours and hours and hours. So I think there's some work to be done on the payment model for hospital at home. As you know, or most of you know, hospital costs are 70% labor, right? It's not the bricks and mortar, those get depreciated. So the CMS model was the full DRG was payable in the hospital at home waiver model. I think they were looking at a 5% payment reduction to make the hospital at home reimbursement permanent. And we certainly have to figure out with our hospital at home partners what the pricing model should be and the reimbursement model should be. But I mean, for those of you that have been to a hospital or have loved ones go to a hospital, being able to get high quality care in your home would be the preference, I think, of almost any of us. So it's certainly something we're really focused on and interested in.
You want me to comment? It was, to Suzanne's point, Medicare driven at the time. And I'll say that as an organization, they did not see the ROI in the home setting. And I think there were a couple of reasons to that. Number one, it's very difficult to talk about prior authorization and evaluate the care and the cost that goes into it. And then the other part of it is, too, that we never built the systems. Talking about building and breaking down systems. As an organization, never truly built the system within our organization around the payment mechanism. Primarily driven because the organization nationally wasn't seeing an ROI in the transition from hospital to hospital at home.
I mean, hospital at home is one that we are evaluating at this point. I think that's something that we need to explore further, and especially the payment models that have been discussed. That makes sense to fund such initiative. I mean, I think we don't question the value of it, the preference to receive care in your home. I think there's huge potential there. I mean, personally, for me, like I've had experience in getting care at home. Like, for example, my 2 daughters were delivered in our bathtub. I got to catch both of them. It was a great experience, right? But I think that concept makes a lot of sense. But I think there are some regulatory requirements that we have to make sure we can comply with as well to operationally provide that setting in a hospital at home. But then again, also collaborating with the payers and making a model that works and that's comprehensive.
So we are paying for hospital at home when we have the ability to get it through MultiCare. And I do think also the payment model needs to be looked at. We need to kind of evaluate how to compensate for the care being done at home.
So I have a question that maybe is too far into the future, but how far are we away from this value-based care, population health, including a broader amount of the population? How far are we from talking to Starbucks and Amazon and Microsoft and saying, hey, you're going to be part of one big population, and those revenue sources are part of this whole model? Are we decades away? Is this not something conceivable? As hospitals and payers, those employers are in your ecosystem. Maybe there's no collaboration with them now, but how far are we away from trying to do something like that? And I say this because some of those companies are actually dabbling in healthcare in other ways, right?
Yeah.
So they obviously care. How far are we from engaging in a three-way conversation with them?
I guess happening.
Yeah, I think it's happening as well. I used to, prior to working for PacificSource, I worked with Cigna on large government accounts, so self-funded accounts like Naples Community College or Arizona, and there's a leprechaun in the back. Sorry, the distraction. But for many years, the conversation has been focused there on what's the fee for service, what's the pricing exercise to do, and now larger groups in self-funded, and George made this comment earlier, we have some work to do as payers and our provider partners to really educate on the value that you get through a capitated basis or a global budget or a value-based arrangement, so that we can do that with them. But they're under the same pressures that we all are under, right? They have rising labor costs. Health insurance continues to be, one of their largest line items. So they need to pull that down too. What our job now is to really convince them that this method that we're using in other populations can also be used there, and whether that be regionally for a company like Starbucks or whether that be more globally and focusing on that work.
Yeah,
Starbucks has gone a little outside the region. I don't know if you heard.
Yeah.
I mean, I think it really depends on what size of group you're looking at. Like a national ASO customer,
Yeah.
Very involved in the total cost of care because it's really costly. You think about like a Nike or a FedEx or another large ASO customer like that that is nationally based. One, they force the health plans to think differently and produce various resources and assets and tools to meet their demands, whether that be the analytics that they need to understand the population and where the hotspots are and what do you need to do to put a different clinical model in place or a value-based contract in place. But they're on the hook. So these large national companies are very involved in the total cost of care and value-based care because they're a global budget.
Do they ever ask you to wipe out the prior auth process?
So I think it's probably going to be customer specific, but anything that reduces costs and prior authorizations naturally produce lower costs. So no, we don't typically see that within these large health system or large ASO customers. There's various. Another example is level funded, which is like a group of small, fully insured groups that band together and act like a self-funded group. That's a big growing population within the commercial space, and they're at risk for their total cost of care. Now, they don't get the complex analytics and care management that a large national ASO customer would, but they're very involved since they're at risk as well. And so I think it's very customer specific, one. these large national customers will demand quite a bit, and they want unique, specific arrangements within each various market too. So it's very much real, and I think it's been real for a long time. It just depends on what line of business you're thinking of.
I would say long term, there's also a public policy play that a large employer like Boeing, who spends over $1 billion a year on healthcare and competes with, countries that don't have the cost curve that the U.S. does in healthcare, will at some point hand it over to the federal government and say, fix this for me, right? And I think the state of Washington is experimenting with universal health care task forces to take a look at it. At one point, Starbucks spent more on healthcare than they did on coffee. They don't want to be in the business of learning and managing what we all have a hard time learning and managing, and it's our business.
What's
so.
interesting, Starbucks is still fully insured.
Yeah. It's a great company for healthcare if their associates, they provide, it's like Costco, they provide great benefits all the way down to their front line, which is unusual and awesome.
So this is a more nuts and bolts question. How often do you guys share, denials data back and forth to try and figure out, how do we fix the stupid stuff?
Very often.
I've never seen it before.
No. Is daily too much hyperbole? I don't know.
I agree, daily or.
So you are sharing that kind of information daily, trying to problem solve, you feel like?
Pretty regularly. I work in the contracting side, and our revenue cycle team, shares with us their pain, right? We need to get this resolved. And it's often tricky to get things at the payer level that are actionable for each payer, but we do try to engage where we see, outliers and trends and things that are particularly. It could be a trend of, a whole bunch of claims, or it could be one egregious, weird denial. But it's become a lot more of our conversation with payers than I think either I or the payer would want it to be.
Yeah, I would second that. Unfortunately, it takes up more time than I would like, and it's not just the claim type denials, but also the type denials that gets in this conversation fairly frequently, right? And that's why, and we're trying to create a more of a collaborative model where we have those different levels try to work it out with each other. Because oftentimes Scott and I become the punching bag internally for these types of situations, right? Like, I get a call from or RevCycle, it's like, oh dang, what did this payer do now type of ordeal, right? But yeah, the data has been shared throughout, going back and forth. Sometimes, part of it is maybe different interpretations of a CMS reg, right? It happens frequently where we believe this is how what CMS is saying. They believe that's that way, and how do we meet in the middle, or how do we find a solution around that?
I would be curious to hear about price transparency that the regulators are talking about, and how you collaborate to make it happen, and what do you see as a path forward?
So there's two different regulations for price transparency. One is for hospitals to have posted their machine-readable files. And I think most are compliant in this market when I look at the data. I haven't seen much impact to patients of that, and we haven't had much contact from payers saying, look at this variation. And that existed before just from COB data. Payers now have to post their contracted rates by provider. And we are getting a lot more, the files are gigantic. They're like terabytes of data. But I think it's a matter of time before there's like a kayak for healthcare that will tell you, this payer has this rate at this hospital. from our data and the payer data. So I think it's going to be really interesting to see, it's all kind of new, and I think people are just learning about it, but I think it's going to be really interesting to see what each side brings to the table in the future after mining some of that data. Again, that's where size and scale are going to benefit you. A small provider isn't going to necessarily have an easy time accessing that stuff, but market opportunity for somebody.
I would just comment quickly. I don't think that is changing the cost of healthcare or changing, the policy is put in place because it is supposed to educate consumers and change their behavior. I've been in this industry a long time, and I don't look at the cost of something, right? Granted, I have insurance like others do, but that doesn't change my behavior, and I've been in the industry for a long time. I worry that some of these policies have a good concept of let's being transparent in price. I don't mind that, but its stated purpose isn't how you go about accomplishing it. And if there's a regulatory body in the room, I'm sorry.
I was given permission to interrupt, and we are over time because you guys have been asking such great questions. So let me start by just thanking again our panel for such timely and informative presentation. So please join me in thanking our panel.